Now? Yeah. So, shall we start? Shall we start, Uma?
Yeah, I gave you a thumbs up. Go ahead.
Okay.
I didn't even see, I guess. Go ahead, yeah.
Great. Yeah. Yeah, good evening, everyone. I'm Diksha. I'll be your host for the session today on behalf of Biome. And welcome to today's session, which is part of our series called the Biome Academy. Just a brief introduction on Biome for those of you who are new to us and joining us for the first time. So Biome Environmental Trust is an organization which is committed to sustainable water and sanitation. And our work is rooted in environmentally and socially responsible practices, including rainwater harvesting, sustainable water supply and treatment, and also land use management. And at Biome, we collaborate with communities, organizations, policymakers, and even informal sector workers like well diggers and plumbers to address pressing environmental challenges. And our initiatives span project implementation, public health, research, policy advocacy, and capacity building. From promoting rainwater harvesting and groundwater recharge to advocating for decentralized wastewater management, our focus is on empowering individuals and communities to adopt these practices. We're also regularly consulted by the government of Karnataka for policy formulation, training urban local bodies, and guiding rural panchayats. Biome's contributions, they have also been recognized both locally and nationally, and we are honored with the Transformative Cities Award in 2022. And through sessions like these, we want to continue our mission to equip individuals and communities with the knowledge and tools to better understand and address environmental challenges. Now, moving on to today's session. Uh, Today's session is about antimicrobial resistance, harnessing environmental cues for public health action. And we are thrilled to have Dr. Varsha Shridhar with us, who is the director and co-founder of Molecular Solutions Care Health, LLP, a company which is focused on innovating diagnostic tests and devices. And she'll be talking more about her collaborative work in India and in tracking environmental cues, and especially for water for data-driven application in public health action on antimicrobial resistance. She's a molecular biologist specializing in point-of-care diagnostics. And Dr. Shridhar is passionate about improving health access and advancing public health research. She was awarded the Biotechnology Ignition Grant in 2018 by the Department of Biotechnology, Government of India, and is an industrial partner in a DST-funded imprint grant aimed at rapid diagnosis of pathogens and antimicrobial resistance in ICU bloodstream infections. In addition to her scientific expertise, Dr. Varsha is a certified NABL internal auditor and an assessor for the Malcolm Baldrige Healthcare Criteria for Performance Excellence, and trained at the Confederation of Indian Industry, CII. She is a strong advocate for empathetic, respectful, and holistic healthcare delivery. So we welcome you warmly, Dr. Varsha Shridhar, and uh, over to you for this session now.
Thank you so much. I forgot that if you tell someone just take my profile from my LinkedIn, it goes on forever and ever. So I'm really sorry about that, guys. I'm also using two devices because on one, the camera doesn't work, on the other, the audio doesn't work. So again, you're seeing two of me everywhere. Apologies for that. Anyway, let's move on. a lot of this work, as Diksha had mentioned, this is a collaborative work, and a lot of this actually is with Biome. I see Nikita here. Srivalli was one more extremely catalytic person in this project, and of course Vishwanath for his mind-boggling brilliance. So a lot of this work is has been done over the past maybe 3 years. So I'll tell you my journey. This also basically this work very closely coincided with my transformation from being a very life sciencey, biomedically person to a more of a public health and a transdisciplinary practitioner. So I'm like excited about having you guys see it. Oh, there we go. I'm supposed to do it this way, I guess. Especially having the Biome group see it and give your perspectives, because I do think that the novelty in perspectives that I have gained from Biome thus far has been so incredibly valuable, and I really look forward to seeing how we can continue this work. So our objectives for today, basically I'll be discussing work in tracking wastewater, water-based cues for data-driven applications in public health. I'm just trying to see why I can't find my own slides over here. Give me 1 second. Where is my slide? Okay, fine. I'm just going to keep my camera here, all right, guys. I'll describe the insights gained from mega-scale rejuvenation of lakes during treated wastewater with a focus on AMR and antibiotics.
Sorry, Varsha, just a second. The screen is not showing your presentation was earlier visible. Now it's not. So
it's not? Okay, let me try again. What is happening? Let's say stop share. And then I'll say share screen again. Any luck?
it's it says you have started screen sharing,
but it's not really showing up on your thing.
Nothing is loaded.
That's very weird. Let's try. I'm just going to do one thing. Uma, I'm going to give you the. Okay, let's see if I can redo this.
I can see your cursor though.
You can see my screen. Is anything?
It's on a black screen.
Got it. All right. Let me share this with one of you. I'll put it in the chat, and Diksha or Uma, one of you, if you can share it on my behalf, that would be much appreciated. Okay. Are you able to access it?
Yeah, I'm just trying to share.
Okay, can everyone see?
There we go. Yeah.
I'll just put it as full
screen. Okay, you've already done. Okay.
Where is it full screen?
It's right on there, that one, yeah. Okay. You can go to the next slide. Great, there we go. So we'll describe the insights gained, like I said, and attempting to connect these things of it, which is slightly sort of, I guess, removed from real world messiness, and to actually how hopefully we can all bring it together. Next slide, please. So the outline of this talk is going to be these 6 parts. Just tell you a little bit about me and my company, what drives us as a team, and then jump into the wastewater related stuff. And what is and how does that connect to antimicrobial resistance? I would like you to think about these questions. Go to the next slide with the questions for you. Next slide. Can you go to the next slide? There we go. So questions for you to think about through the thing. How do you think about the ethics of urban wastewater for rural use? And I don't have to tell you guys, I mean, you guys have been part of this right from the beginning. But for any of the audience members who are not either in the wastewater or water or the one water thinking, I think I would like you to think about the ethics of urban wastewater for rural use. And what do you think about it? And the biome group, even though you've been thinking about this for years and years, I would like to hear your perspectives as well. What are ways by which wastewater would become acceptable to you as an individual, if it's for agriculture, if it's for your pets, or if it's for your own personal drinking water? And finally, I'd like to end with what worries you about AMR. So these same questions I'll be asking you at the end of this session. So be prepared while you're listening to this. Next slide, please. Can we have the next slide? Yeah, great. I started off my life as an industrial biotechnologist with a BTech, switched over to molecular biology for my PhD. And then after 10 years of sitting in a lab, I decided that I was burnt out with science, came back to India and started a company without having any much of an idea as to what a company or starting a company really meant. This was about 9 years ago. Since then, I've become a public health practitioner, especially with a focus on primary care diagnostic systems, and my company is called Molecular Solutions. And it's MSCH as an acronym. Next slide, please. So MSCH really started as an R&D company in 2016. For about 3 years, we delved into developing tests for niche diagnostics. In COVID, we had multiple pivots. I mean, I'm sure it was a transformational phase of time for lots of people. For us, we basically switched to a lot of public health related thinking and public health related diagnostics. We set up Bangalore's first COVID testing center in a primary care clinic, because most of these testing centers, if you remember, were in large hospitals. And so we wanted to see if it could be made a little more accessible to people who may not have had the courage or the accessibility to get to a hospital. And then we started pilot work in wastewater surveillance for early COVID diagnostics, basically because there is a Mori right behind my house, and another person, Angela from Swasti, and I were talking about how do we detect early COVID hotspots. And we came across this paper from the Netherlands where they had basically detected COVID in their canals, in their STPs, 4 days before anybody ended up in the hospital. And we said, if this could be done in STPs, can we just see what's happening in our own backyard? And that was sort of the initial idea of it. Our initial results were exciting, but they were also scary because we had not actually personally seen any COVID positive desks at that time. And then when we saw that in Sheshadripuram itself, there was a little open drain that was showing COVID positive results, and these levels corresponded with the BBMP monitored COVID cases. It was quite a thrill. Because we had these very promising results, over the next 2 years, we basically expanded both the diagnostics as well as the wastewater surveillance. I'll tell you a little bit about it in the upcoming slides. Right now, though, what we really do are sort of 3 main verticals: clinical infectious disease and microbiology, primary care diagnostics, and environmental surveillance. Next slide, please. A lot of the work in the group really started out with this one paper that was published by Vijayashree Yellappa and her team in 2017, which was basically was a qualitative study. They asked a lot of TB patients about their journeys through the Indian healthcare system. And they said, where are all the points at which a patient with TB symptoms might drop off the healthcare sort of process? So on the left top, you see over here, for the most part, when people start showing signs, in this case, it was TB, but really it's any disease when you think about it. You start off with a little bit of self-care, right? You take some tablets, you're like, okay, let me see this, let me see that. You go try to buy drugs over the counter when you ask your pharmacist, hey, I have these symptoms, what do I do? The guy gives you some medicine, you pop it in. And even then, after that, if nothing really works out, you start wondering what's actually going on. You might go to a doctor, typically a private clinic, whether it's an MBBS doctor or any other kind of doctor, you don't really care, but whatever is accessible, right? And then you start this sort of long cycle of going through this process of diagnostics. First, you get referred for lab testing. Then you have to, many times, at least in Bangalore, this is not the case perhaps as much, but in much of India, you have to search and locate the labs. You have to produce that specimen on demand, whether it's a sputum or a urine or whatever it is. Then you have to collect your lab report. Then you have to act on it. You have to take back that lab report and go back to the doctor. Then the guy or the girl diagnoses you and prescribes your treatment. Then you have to have follow-up tests to make sure you're actually getting cured. And then you have further follow-up tests. And finally, after this gigantic, humongous process, which is so burdensome, you're cured. But you can see at every step over here, there is a potential for opting out. And we were basically asking, how do we ensure access to all for timely and appropriate healthcare? Second, next slide, please. This was a paper that got published a few years ago from a real community. So if you take and this was actually in Canada. So it's fairly high resource kind of a place. So if you have 1,000 people in a community who are all exposed to a particular sickness, 800 of them will report symptoms. Less than half will consider seeking medical care. And of that, even a smaller fraction will end up going to an emergency department or to a hospital. And less than one is hospitalized in an academic medical center. Can you just click once? So all our understanding of disease in the country and in the world is based on the data that comes out of the academic medical center, because you actually have people who have the training and the time to follow up and see what's going on. Click again. All our public health systems are based on somebody actually becoming sick enough to visit an emergency or a hospital where there is actually some kind of data capture happening, right? So you can imagine that all our public health systems are very retroactive or reactive. I should not say retroactive. It depends on someone becoming sick enough, basically. And you hope that there are enough systems in place to capture this sick person. Click again. And so what we were asking is, how do we try to be proactive about disease control? Next slide. This is a video, which I think some of you would have already seen. It's a 6-minute video, but please stop at 2 minutes. When there is a little bit of a natural pause, you can just get rid of it. Yeah, go ahead. Can you turn on the volume?
We can't hear the audio, no?
There should be audio. If one, whoever is controlling the thing, can you turn on the audio by any chance?
You might have to share it, reshare the screen along with audio.
Or, in the interest of time, since it's already 4:30, let's keep moving on. Basically, it talks about how wastewater can be an early diagnostic, early screening, sorry. You can go on to the next slide. Diksha, are you the one who's handling the...
No, it's Uma. Uma is sharing.
Okay. Uma, can you go on to the next slide? It's okay. We don't need to go through this right now.
Was everyone able to hear the...
No, that's what you're saying. It was not, we're not able to hear the audio.
Oh, I think it needs to be shared separately. I think when it is on the presentation, the audio, I was able to hear the audio, so I was not sure.
No worries. Anyway, it's 4:24 and I don't want to like take up too much time. So we can continue. I can talk about what we saw there anyway. Doesn't matter. And everybody has the everybody has the link, so you can go and watch it later.
Okay.
You can go to the next slide.
What goes down here?
Sorry?
So it's not going to the next slide.
Maybe the key.
Nice. 1 minute.
Maybe hit escape or something. That might help.
Okay, got it.
Great. So the Precision Health Pandemic platform basically was a coalition. Previous slide, yeah, there we go. Of which Biome was very much a part of, along with TIGS and NCBS, as well as, and this was hosted by Swasti. Angela, whom I spoke about, is basically the CEO of Swasti, and they got funding from a couple of different organizations, including Skoll Foundation. And what we basically did was scale the wastewater surveillance. Water was taken from open drains as well as sewage treatment plants, both by us as well as TIGS and CBS group. And we tested it for SARS-CoV-2. And by looking at these sort of levels of SARS-CoV-2 in these drains, you can kind of tell where is a trend of COVID going up or going down and so on. And we realized you can do it not just for COVID, but you can also do it for influenza, you can do it for respiratory syncytial virus, and you can do it for multiple other things. Can you click? Yeah. Click again. Okay. And one of the ideas that we had at that time was, if you can test for all these viruses in the water, you should also be able to test for antibiotics and pathogens which are antibiotic resistant. I'm not sure how many of you know about antibiotic resistance at this point of time. So should I just quickly give you sort of a, okay, I'll just tell you that instead of wasting more time. So it's like when you assume that when you have an infection and you take an antimicrobial, whether it's an antibiotic or an antiviral, that this particular drug will kill the pathogen, right? That's causing this infection. And the hope is that the pathogen level goes down and you become better. But the thing with these pathogens is that they're also living creatures, and this is a dynamic system. We tend to assume that, bad thing here, antibiotics are a good thing, they fight and the bad thing dies. But over here, the pathogen is also in a very dynamic system, and it's also constantly evolving. So when you have these levels of antibiotics or antivirals, and nowadays there are also cancer drug resistant cancers and things like that. So basically, when you have this living system where things are constantly responding to their environment, you end up with a situation where your drugs just don't work anymore, because the particular pathogen or your cell has evolved ways of kicking out the drug itself. So resistance basically ends up, and in a real life situation, you can tell when the drug that you were taking no longer works for you. For this, actually, a lot of women would have experienced this in real life, assuming, I'm not talking about the people who are really sick in the hospitals. I'm saying in general, day-to-day life, women experience a lot when we get urinary tract infections, because women are very prone to UTIs. And then after a point of time, you stop going to a doctor because you know what drug will work for you. So you might just be able to get a Cipro or something. You pop it into your mouth, and then you'll see that maybe next year or the year after that, those drugs don't work and you have to end up going to the doctor anyway. And this is because the pathogens that are infecting you have now become resistant to that. And so we said, let's look at these open drains and look at hotspots, not for regular use drugs, but for drugs that are used as last line medications in hospitals, which can only be given through the IV, intravenous route. Somebody has to inject it into you for it to work. These are a class of drugs called carbapenems, and they're only supposed to be used when every other class of drugs has failed. All right, so these are kind of like our final sort of frontier of antimicrobials. And what you see over here is these little golu red or brown spots are all the places where we found high levels of carbapenem resistant pathogens. And then in the red circle with this thing are basically the health sort of hospitals over here. These are tertiary care hospitals nearby. Because the assumption was, if you're seeing this much of carbapenem resistance in your water, these are all open drains, these are not STPs. In your open drains, where are the antibiotics coming from, which allows the survival of these pathogens? Because these pathogens are not going to continue to hold on to resistance in the absence of an antibiotic. So if these are high levels of pathogens which are resistant to the antibiotics, it also means that the antibiotics have to be there in the first place to allow them to survive. So then, if these are only antibiotics that can be given through the intravenous route, where is that antibiotic coming from? It has to be coming from a health system. It has to be coming from a hospital, which is using these antibiotics and probably discarding them inappropriately. What we should have done in this study was actually measure the levels of those antibiotics. We didn't have money to do that, but we do that in the next study. So this was a little bit of an eye-opener for us to say, wow, these are actually really high levels of, these are actually a lot of hotspots for carbapenem-resistant pathogens to be found. Next slide, please. Any questions or comments over here? Okay. Avinash, go ahead.
Yeah, Varsha, I didn't understand the part you said that about the microbes needing antibiotics to survive. I thought they're antibiotic resistant, but in the absence of antibiotics, they don't. Is that what you said? Am I understanding rightly? I didn't understand that.
Yeah. So think of this as a dynamic system, right? So you have an external pressure. You're saying, okay, I'm going to put in all these antibiotics to kill these bugs. Then the pathogen, the bacterium, evolves a way by which it can stop the antibiotics from entering it, or it breaks down the antibiotic or whatever. It stops it from functioning. But if you don't have a continuous pressure, evolutionary pressure, for these pathogens to think of it as this pathogen has now taken on extra baggage. It is producing things that it typically would not have produced. So it's actually in some ways a burden on that pathogen to hold on to this extra strength that it has gained. And the only reason it has gained it is to fight against the antibiotic. Now, if there is no antibiotics, over time, the pathogens lose the resistance markers. It loses the ability to fight off the antibiotic. It's sort of like if you have a little luggage, if you have a little suitcase that you have to carry around for a particular purpose, and when the purpose is no longer there, you drop that luggage. You don't want it anymore because it's a burden for you to keep carrying it around. You know what I'm saying? Does that make sense to you?
Yeah, got it. So AMR is the resistance is reversible. That's effectively what it is, right?
Exactly. For the most part, there are some cases, as with any biological system, there are always exceptions. But for the most part, these are things that can be shed and taken on, depending on the environment around that pathogen. So if you have levels of, if you have continuing levels of antibiotic-resistant pathogens, it basically means there are antibiotics in that water, kind of inducing the pathogen to hold on to those genes that cause the thing. Yeah. All right. Any other questions? Okay. So how does the early warning system work? It basically, I'm just going to switch back to the viruses now. I'm sorry, I realized that this should have come the previous slide. Most pathogens which give you, let's say, a respiratory illness or many things actually, not just affect your respiratory system, they also affect your gastrointestinal system. If you remember, when the first few descriptions of COVID was kind of being spread through various, WHO and ICMR and things like that, they said symptoms of COVID are you lose your sense of taste and smell. You may also have diarrhea. And this is for COVID, but this is for a lot of other infections as well. And many of you might have noticed when there is a rainy season and you end up with a cold, you do also sometimes get diarrhea or constipation. Your gastrointestinal system is also affected, right? So a lot of pathogens that are known to be associated with one system also end up affecting other systems. So invariably, for a lot of pathogens, they get shed in the stool or in the urine. So if you can have a dipstick in this wastewater that comes out of a community, then you kind of understand what kind of pathogens are kind of floating around in the community, so to speak. All right. So in this case, in blue is the wastewater levels, and in red is the clinical cases. And in COVID, at least, we see that it works out very nicely, where you can see the COVID levels in wastewater arise. The peak arises earlier than the clinical peak. And we saw this in the third wave, both our own group working on the both in open drains, in the STPs from Dr. Farah's data, and when you have a combined version of open drains plus STP, you see all these things quite nicely. Next slide, please. So what I've shown you, well, I've not really shown you this, but I'm telling you this at this point of time. Wastewater surveillance was able to detect hotspots before clinical cases. But the only reason we were able to do this was because we had that kind of incredibly high levels of data coming out for SARS-CoV-2. For other infections like influenza or anything else, you can't really see this as much because you just don't have clinical information. So you can't really validate your wastewater information. You can take it, you can sort of assume that this works for other infections and start testing wastewater. But honestly, it's not going to have a lot of scientific merit because you have not shown that it truly corresponds with your clinical cases. Next slide, please. So this is, I'm going to switch to AMR now because that was the whole point of this talk. This is a report from our own lab. If you go to the top sort of right corner over here, you can see this is a 6-month-old baby boy. Oh, sorry, a 7-month-old baby boy who, this was done in our lab in October last year. And this child is in the ICU. And this is a urine sample. And the urine sample basically grew E. coli, which is a very common pathogen. You must have all heard it from the coliforms. The coliform part comes from the coli over here because it comes from the colon. And CRE basically means it's carbapenem resistant. You can see over here, these are the, underneath that is this long list of antibiotics. And this is, this particular pathogen is basically resistant to everything except for the first 2 antibiotics, fosfomycin and tigecycline. But unfortunately, because the child is so young, you can't actually use those 2 drugs. So it's kind of pointless. So this kid basically was infected with a pathogen that was resistant to pretty much every single antibiotic in the arsenal of a healthcare system. And this is something that we are seeing a lot of. And then, of course, it begs the question, where is this child getting exposed to these kind of pathogens? Why should a 7-month-old baby who presumably, and this 7-month-old was not, sick, was not exposed to antibiotics in utero, was not exposed to antibiotics in the first few months of life. Why should a baby who's presumably been at home throughout its life suddenly be infected with such a horrible and resistant set of pathogens? And this has sort of been a recurring question, especially in the Indian context, I would say for the past decade or so, where you see a lot of these kind of multi-drug resistant or XDR in terms of TB, but you see a lot of multi-drug resistant infections in the population, even when the populations have not been exposed to certain antibiotics before. They may have never gone to a hospital before. They may have not taken this antibiotics before, but they are still getting infected with these resistant strains. And that begs the question, where are these coming from? And for the longest time, the assumption has been it's coming from the environment or it's coming from the food. And I'll tell you why in a little bit. You can go to the next slide. Yeah, click again. Okay, I hope this is not too blurry for you guys. So if you look at this, in the past 20 years, we've actually increased our own human consumption of antibiotics almost by 36%. But while a third of all antibiotic usage is by humans, the vast majority of antibiotic consumption is actually by animals. Because sometime about 50 years ago, people realized that if you feed animals antibiotics, the weight of the animals increases. And so this obviously has a very clear incentive, financial incentive, right? So a particular chicken or a pig or a cattle or a goat can give you a lot more money per unit. If you click again, yeah, 70% is by animals, and here we go. And click again. I just want to highlight two other points over here. Yeah. Not all the antibiotics either we consume or the animals consume actually get used up in the body. About 80% are just shed, unbroken and unconsumed directly into the through the feces or the urine. This is expected from a pharmacological point of view, but it also means that you have unbroken or unliced, lysis is a very fancy word, but undegraded antibiotics going directly into your water systems. Click again. So if your antibiotic concentrations are high enough, they will kill the pathogens. There is no question about it. But then if they are sublethal, they're slightly lower, which means that the pathogens are not getting killed by these antibiotics, but they are now induced to produce genes that will help them combat these antibiotics. That is the sort of the condition in which you have antimicrobial resistance. So it's not a question of yes or no, but it's a question of how much is the concentration of these antimicrobial agents in the water. And you guys know this way more than I do. But we know that if the water goes either into the STPs or into the underground drainage or into the open drains, there is always a fraction of that water that goes directly into lakes and it's used in agriculture and things like that without getting treated. And it also begs the question, how good are our treatment systems? Assume you have amazing treatment systems. Are these treatment systems enough to remove antibiotics? All right, next slide, please. Any comments or thoughts so far?
Actually, this is also the reason why people are given an antibiotic course for a certain number of days.
Mm-hmm.
That you have to take it for so many days when an antibiotic is prescribed and not stop taking it once you start feeling better.
Absolutely.
Because the antibiotic needs to eliminate that pathogen from your body.
Correct.
Otherwise, if you stop, if you are prescribed an antibiotic for 5 days, and if you stop taking it after 2 days just because you feel better,
Mm-hmm.
you feel okay, I'm okay now, I don't want to take. And most common thing is probably for respiratory infections,
Mm-hmm.
or as you said, for urinary tract infections. The same thing happens. The pathogen is not eliminated, it's not killed, but it starts developing resistance to that antibiotic that has been given if you don't complete the course.
Exactly. And with just a 2-day or 3-day thing, again, the concentrations become sublethal. And so you're basically incubating, you're allowing these bacteria to develop resistance inside you. So the next time you get infected, you will be infected with a resistant organism, not with this thing. So let's just go to the Kere Sanjeevani project a little bit. I can see Nikita is here. And a lot of this work was really because of her and Srivalli's help. Okay, we can click again. So this is, you can remove that. We all know about Bangalore. Like, I'm assuming most of the people here are from Bangalore. Let's go to the next slide. This is basically showing the taluk level agricultural drought occurrence, showing that almost every district surrounding Bangalore is extremely limited in water resources. Next slide. And this was an old Deccan Herald picture, which I think all of you would have probably had better pictures. You've probably seen them. But this is showing that about, so about 1.6 million or 1640, 1,600. I was going to say 1.6 billion, but I think that's a little too much to say. 1,640 million liters daily is the wastewater that's generated. And initially, the idea was that they would be treating about 770 million liters to treat it and then to transfer it to the arid regions around Bangalore. Next slide. Oh yeah, and the focus of our work was Chikbalapur in this particular thing. So I'm just going to, yeah, go ahead. So I'll just talk to you about the context behind the work. We got 10 lakhs from the from a BIRAC grant, which is Biotechnology Industrial Research Grant, because they wanted to get products that would indicate some connection with One Health. I don't think they were especially expecting this kind of, whatever we did over here, which was basically to like test everything and put it up on this dashboard and stuff like that. And we said the dashboard is our product. At that time, they were like, okay, but as long as you can show that you can, patent it and sell it, we are quite happy to fund you. And I was like, well, you can't patent a dashboard, but hopefully there'll be buyers. Thankfully, because the typical mandate of funders tends to be, do you have a product that you can sell, at least in the biotechnology department. So we had one person who was like, you know what, this actually seems like it's true One Health. And instead of always saying we want a product, let's actually try to see if we can get some knowledge out of this. And thanks to this one person who was a bit of a champion for this, we were able to get even this small amount of funding. We said, so with Vishwanath's help and guidance, we said, okay, let's look at Chikbalapur, because we knew that the IISc group was already doing the Kolar impact studies. And we said, we don't want to do an impact study as such. We want to look at, we want to be able to create these interactive dashboards where people could actually look at what's going on and hopefully be able to use it in their decision making from a implementer point of view. Next slide, please. These are just sort of the satellite images of these lakes that were taken in 2018 and 2023. And you get beautiful, you get nice things. These are all from Google Earth. While the IISc team had done this in Kolar and shown that, agricultural output actually increased, I thought this was a nice way to kind of visually show that, you can definitely see there's more green cover at least in these areas. And you can see this for pretty much every lake that was part of this Kere Sanjeevani, who's getting this lake where the water is now kind of, where the lakes are now being rejuvenated by this water. Next slide. So the 4 lakes that we chose were Bagalur in Bangalore, Sihineeru in Devanhalli, AGK, which is Ammani Gopal Krishna Lake, and Kandavara in Chikbalapur. And AGK and Kandavara are actually fairly close to each other, but surprisingly enough, have very different types of ecosystems. I don't think I have too many slides about that. I'll just tell you a little bit, because AGK actually has a bit of a wetland kind of an ecosystem. So you have a lot of cranes and ibises that come there. Whereas Kandavara, as you all know, is mostly just like a actual just full water lake without too much, unless there is some degree of algae growth now. It's mostly just water. And so the kinds of birds that come there and the ecosystem that is kind of developing there is very different. Next slide. So these dashboards looked at green cover, as I said. Next slide. I have 10 minutes, so let's just see if I can go through this fairly fast. This is the dashboard. We had called this a Kere Sanjeevani water quality dashboard. And then we showed this to somebody in Uttar Pradesh who was looking at Ganga sort of quality of water and things like that. He said, what you guys are not, you're not doing water quality, it's actually a living cities dashboards, he called it. So then we said, okay, sounds kind of nice. What you can do is basically click on the lake of interest. This is a map over here. This is a link over here. I'm not sure if it is active anymore, because I have a feeling Swasti guys might have run out of money to sustain it. But we can go back and check. I haven't checked it in a while. But basically, you can click on the lake of interest. You can click on the attribute that you want. And these attributes were actually from the data that Biome generated, where you had all the BIS standard parameters. So not just alkalinity and things like that, but also many of the heavy metals. So we had done this. We also went to send this water to IISc for heavy metal testing, and we sent it to another group for antibiotic and antifungal presence. And then we tested both the lake water and open well near the water, near the lake, usually owned by a farmer or somebody living there, or a bore well. So we had, for example, at every of these things, we did 3 of these at multiple and in a longitudinal kind of a way. Next slide. So for example, if you click on Bengaluru and you say, I want to look at alkalinity, then you see that the lake and the open well and the bore well, the panel to your right shows these things. And it also gives you a kind of a red, yellow, sort of orange, yellow, green kind of a thing. So alkalinity was a little bit high, but if you click on other attributes, especially the heavy metal attributes, they were all well within safety limits. And you can also tell what kind of bacteria we grew from that water and what kind of sensitivity profile it had to what kind of antibiotic. Next slide. Okay, before I come to the 2 opposing sides, can you just go back, because I realized I didn't put up the screenshots of those. So if you look over here, it says water quality dashboard underlined, right? Under, you see introduction, water quality dashboard, and then you also see a birds dashboard. And this was, I think, the thing that also kind of was unique in some ways in this project, because we said, let's not just look at water quality as such. Let's also interview farmers and their families to find out, has there been any changes in their health? We interviewed the PHC doctors and the private clinic doctors to see if there was any change or difference in the trends of the infections that people were showing up with, especially if they lived near the lake. And then we looked at, we did multiple counts of birds. Ideally, what would have been good was if you could actually get the historical counts of birds from, let's say, from like 2018 or something like that. But if you go to a dashboard like eBird, you get things like, rock pigeons and and sparrows. You don't really get any kind of birds of like what kind of migratory birds are coming. Are there increases in that? But we did see a lot of migratory birds in many, especially near AGK and all that stuff. This was a 6-month project. So whatever, I think we did this 3 rounds of bird counting. And we did see a pretty spectacular diversity of birds and count of birds, both migratory as well as non-migratory. So this was actually really reassuring and quite nice for us to look at. Not to mention, it was very lovely going there and just doing these kind of things. Next slide. So the 2 opposing sides of the debates, actually, I got these from conversations with you guys, so I don't actually really need to be talking to you about this. If you can just click. Yeah, go ahead, Avinash.
Varsha, what about learnings in Kere Sanjeevani for the lakes that you'll have actually looked at? What's the learning from an AMR perspective? You talked about heavy metals being thing. You talked about
yeah, I'll show you that. I think I have a slide on that coming up. Or did I accidentally? Give me 1 second. Let's see if I have it coming up over here. I hope I've not deleted it. I have not deleted it. Okay, good. I'll just show you that in 1 second. It comes after the opposing sides thing.
Okay. Sorry then.
No. My fault also, because I had done this. I had taken a few slides from different things, and I was just like, I hope I put that stuff in. Yeah, you can just click, Uma. I have 7 minutes. Yeah, I'm not going to go into this. Click again. Or should I go into this? I guess we can talk about it in the discussion period. You can, yeah, we talked about safety. You can go to the next slide. And these are impact assessment data from the Kolar study from IISc. So I'm not going to go into that. I'm sure all of you have already seen these things. Click. Click again. And again. And this is where we're talking about AMR and antibiotics. So if you click again, yeah, again, there we go. So these were the antibiotics that we found. All the other antibiotics that we looked at, both at various levels, whether it's a simple one like a penicillin and its sort of relatives, or cephalosporin and their relatives, all those things. So we went to multiple classes of antibiotics. I think we had studied about 19 antibiotics and a couple of antifungals. These were the ones that kept coming back as positive over and over again. The highest levels were seen in this particular drug called isoniazid, which is the drug for TB. So isoniazid is the main drug given for TB patients. And about a year ago, it's also started to be given to family members of TB patients as a prophylactic, to say, okay, you are at high risk, take this antibiotic and this thing. Isoniazid is also one of the first drugs to which TB becomes resistant. So you actually see very high levels of, or you can expect to see fairly high levels of isoniazid in the country. So this was actually quite concerning. I'm not that concerned about amoxicillin or fluconazole or linezolid. Linezolid is a little surprising to see high levels of, because it is one of those IV drugs that people are given. But the isoniazid was actually the one that was most concerning to me. And this was something that we saw at least 2 times in our longitudinal study. And so yeah, that is basically, this actually triggered a lot of the next round of grants that I wrote were actually for TB, looking at drug-resistant TB in wastewater based on this data. But we haven't yet got any money for it. So let's see what happens with that. Avinash, any thoughts or questions about that? Or anybody else?
So these are levels of the drug itself, right? So this is coming after people have taken it and through their poop and pee, or this is coming directly into waterways in different ways? I mean,
yeah, hard to say. So these are non-degraded drugs. So it could be that this is being shared undegraded through the poop. Or I actually wonder, because if it's quite high, I actually wonder if people are discarding their drugs over here into the water. And I wonder if that's one of the reasons why it is consistently high as well. I'm just showed you one particular time point over here. But when we did it 2 or 3 times, we saw this. Yeah, thank you, Arun. I will definitely reach out. But yeah, so I don't actually know where this is coming from. So when I showed this to the TB, I went and showed this data to the state TB prevention cell, STEU, state TB elimination unit, sorry. And they were like, well, this is a little surprising. Nobody's supposed to be dumping these drugs into the water. But at the same time, we don't know if they're actually dumping it or not. We have no way of tracking what is happening with these drugs. So I don't actually know from where this is coming.
Yeah, it's possible people generally have a habit of flushing their expired medicines or unused medicines down the toilet. Plus, even where there are these programs for collecting back unused medicines which are still not expired, or expired medicines, I don't know whether they actually send it through the actual, because that costs money, right, to kind of
correct,
get rid of the medicines in the correct way.
It could, yeah, exactly. Or I mean, is it coming from patients themselves, or is it coming from
hospitals?
Health, yeah, exactly. Health facilities. These are things that we have to really kind of look into to see who's throwing what. All right. We can. Other thing I also want to point out over here is you can see that the STP inlet and the STP outlet, if you look at the first 2, 3 sort of these things, there's not really a significant difference. It also tells you that there's, especially in this isoniazid, because it tells you that, the STP is not able to take out some of these antibiotics. It is taking out many antibiotics for sure. Or at least there's no difference at least between the inlet and the outlet. So I can't say the STP is taking it out, but you don't see too many antibiotics in the STP, but you don't actually see a reduction in these antibiotic levels from the inlet to the outlet. And I thought that was also kind of quite interesting.
And the bore wells also seem to have higher of the isoniazid, right? And in
Yeah.
some of these cases, yeah.
Correct. And I think again, it depends on the drug itself. Like if some of them have these very long half-lives, some of them have very short half-lives. And so it comes back to drug stability, exposure to sunlight, a lot of these things. There was one study, the very first study that Rakshita, Nikita, people from my lab, Imon, etc., had done was looking at the pathogen levels in the sludge and in the wastewater, in untreated wastewater. And they found out that basically if you take the water untreated directly from the source, and then you know how farmers keep it out in the sunlight for like 3-4 days, and then you test it again, you see a huge reduction. The sunlight itself is a very beautiful natural way of killing off most of the pathogens, and it's also a very good way of degrading antibiotics. So these are things I think that are like really interesting for us to do, to be able to say, okay, you have these antibiotics here, but what are cheap ways by which we can actually remove them? Does it have to be a massively complicated new thing that you have to add to an STP? Or can this be something that can be done locally to say, okay, you get this water, you put it out there? If non-degraded drugs are the ones detected, could it also be that degrades leads? Exactly, yeah. It could just be that it's much more stable and it has a higher half-life, absolutely.
So, I mean, this is after the treatment of wastewater. But now, say if we are further treating that wastewater with any tertiary treatment or the WTPs that are there in our apartments. So does that kill off all these or does that remove these antibiotics further? I mean, does further treatments of water reduce the levels of antibiotics, or does it stay the same?
I don't know, because I don't know what kind of, we've not tested it, so I don't actually know.
Okay.
All. But I also don't know what kind of testing processes are conducted. Like, what is the difference between the STP treatment and the WTP treatment in an apartment? I would not be the right person to, I think these are the kinds of questions I think that as a group, when we co-develop and co-learn, I think these are the kinds of things that will come out of this, to say what are these real world, real life questions, you know?
Okay.
Okay. Shall we move on? Or...
It's interesting that in 2 of these bore wells, amoxicillin levels are higher than at the inlet or the outlet. Like the Kandavara, near the Kandavara bore well and near the AGK Lake bore well. You see the blue there is taller than either at the inlet or outlet. So that the amoxicillin is getting concentrated in the bore well water.
Potentially. Again, these will have to be done a few times. These were only done twice. So typically in these things, you do it in triplicate, you do it in twice, sure. But again, because it was such a short project, I also don't know what kind of environmental factors were also in play over here, because we could not get it through multiple seasons also, right? Like in this season, this was mostly in summer. Was there this kind of water because there was I don't know, was there some kind of seasonal effect on this? Not sure.
I think one thing that might help, I don't know how that will work out, is that one is to check the levels after treatment of wastewater, but also check levels of these. I mean, I'm not sure if this occurs only in wastewater or in fresh water, but in similar area or in the same areas, if we are finding what are the levels of these antibiotics in normal water, like which is not wastewater. So that could also give maybe like fresh water or water supply that is directly coming into the homes and all.
Yeah, definitely, for sure.
So that comparison could help, because if there are high levels there as well, again, but I'm not sure if these antibiotics are could be found in the fresh water supply or not. But if there are like levels there, but so then that will give a good comparison of why it is happening more in certain bore wells or certain lakes also.
No, lakes is understandable, right? Sorry, go ahead.
No, I was going to say, if Nikita is here or if Vishwanath is here, do you guys have any thoughts on these? Things
Yeah.
about
So, Varsha, one of them is to start to establish this, whatever you call the permissible levels of antibiotic residues in water, right? There's still enough, lot of work to happen. But what we are doing in the water treatment plants is to increase the activated charcoal, activated carbon filters, and activated carbon filters absorb
nearly all antibiotics. Yeah.
antibiotic residues as well as pesticides. So one of the things we've done in senior care is to increase the activated carbon filters from phase 1 to phase 2 to take care of this. But we will test there also. We will again figure out what needs to be done. And so there's a testing ground available.
Sounds good. Yeah, we would love to be part of any of those tests, just through thinking or anything like that. Vishwanath, would love to know how that works out.
Yeah, sure. We can continue the conversation here because we are the only sort of group which is bringing together all these things, right? If in the Career Sanjeevani project, all these studies are being brought together. So let's continue to push ourselves on that work.
Absolutely. Yeah, the activated charcoal is actually one of the, whatever I've read, because we use this again. This was one of the things that we had proposed for this UP study I just mentioned before, and Vishwanath was also part of that, to basically see what is the efficiency of, say, something like a duckweed, which is a phytoremediation agent, I guess, which is also supposed to be extremely good at removing antibiotics, versus, say, an activated charcoal in terms of cost and space availability and time and reusability. Like, are you now, by having all this activated charcoal, what is the sort of, is that a sustainable solution versus, say, a duckweed solution? But again, from what I understand, the duckweed probably requires a lot more space than the activated charcoal. Can't be compressed.
So Varsha, is it only duckweed or can it be like a similar species of duckweed? Because I think we've found quite a few lakes which have a lot of duckweed like overgrowth. So
right, actually I learned this from I mean, the first time I heard about any of these phytoremediation things was actually in that Jakur Lake. You know, they've created that thing. Rakshita and Nikita were the ones who showed me this. And basically, I think there was a cat's tail and there was something and all. There's multiple things. Duckweed specifically has been tested for antibiotic removal. Now, I don't know if the other ones have been tested for specifically antibiotics.
okay.
Okay, shall we go to the next slide? I'm not going to go into this. I think you guys know this way better than I. So let's move on. Yeah, so there's just a summary saying, this is again a concept I learned recently from conversations with Avinash and Vishwanath about this whole idea of one water. You know, you talk a lot about One Health, but this thing about circularity of water. So, can we actually reuse wastewater? And it is emerging as potentially the only solution to critical water crises. It could be a method of finding AMR hotspots. Could it also be a conduit for transfer of AMR? One of the, I think the scary things over here is you have, of course, a huge amount of antibiotic usage in urban areas. Are we now kind of pushing all this from the urban to the rural area? And if this is a risk, then how do we sort of mitigate that or de-risk this whole thing? Next slide, please. Yeah, Avinash, go ahead.
Just to that point, so that slide you shared, Varsha, showed the antibiotics as is that is detected in the lakes. That slide. But in terms of antimicrobial resistance, what is the next level of tests? And in the Career Sanjeevani, we've been able to understand something in terms of the antimicrobial resistance itself. How does that work?
Actually,
finding antibiotics is one thing, but finding that there are pathogens that are getting resistant is a kind of a next level thing, right? So how does that work?
Yeah, so we have some of that data because it was there in the dashboards, but of course I didn't show you to you over here, but I can share the data with you about what kind of pathogens we found and what were the resistance levels over there. We did not find resistant pathogens in the specific antibiotics that we looked for. And like I said, we were looking specifically for things like carbapenems, which you can tell even from this graph that there were actually 0 carbapenem antibiotics found. And we found almost no carbapenem resistant bacteria. We were also looking at other kinds of beta-lactams and fluoroquinolones and things like that. We did not find resistance against those. We have not tested for drug resistance against any of these fellows. Isoniazid, we did not test. Fluconazole and all we did. So isoniazid and linezolid, we never tested in terms of for the bacteria because it never struck our mind that you would actually see these particular antibiotics. Amoxicillin, even though you see antibiotic levels here, we did not find significant levels of resistant bacteria to amoxicillin. And fluconazole is, of course, antifungal, and we did not do that. So out of these 4 antibiotics which we found in the waters, we found low resistance or negligible resistance to amoxicillin. We did not test the other 3. Yeah, all right. Okay, next slide. So oh yeah, go ahead, Avinash.
No, that was an accident, sorry.
Oh, okay, fine, all right. So, in epidemiology, we always look at things in triads. We say agent, host, environment. And then in AMR, I thought, what would be the triad? And it's basically the biological, social, and ecological. And if you can just click once, Ma. So from a biological perspective, we as biomedical scientists are very comfortable talking about, which pathogens, which genes, how does one gene jump from one organism to another. Those are all fairly, I think those are the standard questions that people ask, but we very often forget to ask the other questions related to this because AMR is a classic example of a biopsychosocial-ecological problem. Right? So we are not asking enough questions about, say, who interacts with the wastewater, what is the extent of interaction, how does their occupation sort of, is there a risk, is there no risk, if there is a risk, how do you mitigate the risk, and how do various components of the wastewater also interact with each other and influence the AMR. And then in the ecological part of it, things like I just talked about seasonality over here, but also things like terrain, because when you have movement, again, I just spoke to you about how dynamic the interaction between a pathogen and a drug could be. But when you actually have physical movement, that because of terrains, because of wind, or just because of seasons, that could also have a huge effect on actually what ends up happening over here. I don't want to, again, make this into a doom or a gloom kind of a thing, because we know that nature itself is actually fairly good at just sort of removing many of these things just through natural sort of processes. For example, I would assume, for example, after Kandavara, if you were to look at a bunch of downstream lakes, we may be able to find even fewer amounts of antibiotics just because it gets naturally absorbed by the terrain itself. But I do think one of the other things that we should look at are bird, fish, amphibian populations. Fish kill, as we know, is obviously a big indicator of bad waters. And we've seen that in Bengaluru. And we've also seen that within lakes inside Bangalore, which are not part of the case in Sanjeevani. But we know that the waters are not great. But can we actually use this to look at ecology and ecological systems as a whole? And yeah, that's basically what is the access to people's sanitation, hygiene, services, etc. That's less ecological, I think, more biological. I put it in the wrong circle. Next slide, please. And I just wanted to appreciate again how much I have learned personally from our interactions with Biome, because this has been true transdisciplinary work. I think 4 years ago, when I first heard about the Sanjeevani project, I was like, oh my God, so bad. Treated wastewater, it's going to be so bad for in terms of health. And then just listening to all of you multiple times over the past 4 years, there has been definitely transformations the way I think. And I think that's truly one of the most transdisciplinary projects I have been involved in. So thank you all for that. Next slide. And I think I'm mostly done with this, if I'm not mistaken. No, I'm not going to talk about this. Let's move on. Yeah, so what I do want to just kind of talk about is how this idea of one of the work that we are also doing is an OSH, which is Occupational Safety and Health for Migrant Workers. And a lot of the narratives I hear from, say, workers in Bommasandra, which is where we have our clinic. These are workers from Odisha or Assam or Bihar who've come to Bangalore, definitely not living in great conditions, but compared to perhaps their conditions either in their hometowns or in other places like Surat or Ahmedabad, the conditions here are slightly better. And the narrative that you keep on hearing over there is, oh, we had to leave our farms. हमें खेत छोड़ना पड़ा क्योंकि पानी नहीं था. Our fields dried up. We had no way of doing anything else. Our kids are there, or our parents are there, but we had to move because there was no other way of survival. And one last thing I wanted to bring up with this, if you can go to the next slide. So this is actually a map that we did from our work in Bombay and Pune of migrant worker deaths. So these are all migrant workers who've come from, pretty much you can see the Gangetic Plain over here, though not just the Gangetic Plain, that's the highest proportion perhaps. They've come to Pune or Bombay and they've died over here because they're working in these dangerous, dirty, difficult jobs. And almost invariably, the narrative over here was, we did not have water. And this was despite living in the Gangetic Plain. And we had to leave our farms because of this. So I thought this was actually like such a kind of, in some ways, going full circle. Like the whole point of us doing all these things and this project doing all this happening in Bangalore is so that ultimately it can get scaled. And there are real consequences to, water crisis across the country. So I just wanted to kind of add that over there. And I think the last slide is basically my coming back to the questions. This is my last slide, and I'll leave it there.
Varsha, do share that two-side slide which you wanted to pose kind of diametrically opposite things of a debate.
Oh, yeah.
I think that would be good to bring in as a part of this conversation.
Uma, can you just go back to that? Yeah.
Varsha, I also wanted to check with you that when you said like this half-life or residence time of these antibiotics, what does that amount look like? Like,
it changes very drastically between antibiotic classes. For certain antibiotic classes, it's only a few hours, like 4.5, 10 hours.
Okay.
Like that. Certain ones, it's many days. And again, this also has to do with the formulations. Like, sometimes you'll have the same antibiotic could be kind of slightly modified so that it's a longer acting antibiotic, so the patient doesn't have to keep taking the medicines too much. So those kinds of modifications we don't have the ability to test for at this point of time.
Okay.
But at least in terms of broad classes, there's quite a variability. It depends on exactly which class of antibiotics you're looking for.
Okay. But like the range would vary between, like you said, a few hours to days, weeks.
Yeah.
Can it go to months also?
Unlikely, I think.
Okay. Yeah. That helps. Yeah. Okay.
So, Avinash, you wanted to stare at this a bit, but what are your thoughts?
No, Varsha, I just wanted you to share it with everybody and kind of explain this slide also.
Sorry. I thought I think
interrupted
no.
then. Sorry. Yeah.
I would like us just to discuss it, like stare at it, and what are thoughts that come to all of you. Many of you have been working on this, and I'm sure you also would have gone through your own sort of personal evolutions in thinking. What have been? Let me ask you all this.
I mean, even here, Varsha, just a question, like politically sound on the right-hand side, is it always, or in this particular case, it has been, right? I'm not sure if it's
Yeah, I also don't know. This
going to be political sound. Because, I mean, the other three, yeah, sure, like wastewater, like you said, in the context of water scarcity and water, like, water stressed regions, that the reuse of wastewater largely stands, even, I mean, for agriculture, for drinking water purposes, etc. But in this case, politically sound in what sense? And if and also depends on land use, right? If land use is more domestic and not industrial, then there's a context in which wastewater reuse is possible.
Absolutely. So this actually we got from one of the guys we had interviewed at Kandavara. I don't know if Shivali is here because she was there on that thing. And the guy was just like, who was the guy who was an MLA from Chikbalapur? He was the health minister during COVID. I forget his name. Sudhakar. He's from Chikbalapur, no? So we were just talking to a few people around, saying, hey, what are your thoughts on this? And he actually had a whole T-shirt with Sudhakar's photo on it, and he had the BJP logo, and he was like, this is the best thing ever. And this is a main reason why people voted for Sudhakar, and this is the main reason why BJP is in power. This particular thing is so good for everyone. There is absolutely no negative effects to us. And I was thinking, oh, that's a pretty good branding exercise that these guys have done. So that I was coming from there. And I think from conversations with you and Vishwanath also a few days ago, it sounded like there is a lot of demand for this from various constituencies and things like that. So actually you should talk about it, I think. So I agree, like it could be a land use thing, but it did seem like there was a lot of political mileage that people were getting out of it.
So Varsha, one thing is that it's not just urban wastewater for rural use. There's also urban wastewater for urban use first. But there's so much wastewater that we can fill all the 186 lakes and still have more than 1,500 million liters per day for rural areas. And the question that we were asking was, should not agriculture also have a charge on this wastewater, treated wastewater or treated used water? Or should it only be urban areas and industries, right? So it's more complex than just urban wastewater for rural use.
Okay, I see. That is actually good to know. I don't think I caught that in all our conversations thus far. That this 1,500 thing is after it's already been used, I guess, by industries and things like that, right? In the urban system.
Way more. So the first lakes to be filled were in urban Bangalore. Jakkur was one of them. There was Dodabamasandra, quite a few which have been filled with treated wastewater. And there is fishing activity and other reuse activity in the urban areas. Now the surplus is also going to Kolar and Chikbalapur because they have no access to any other form of irrigation water.
Oh, okay. So there's actually surplus. What about all these other urban lakes that we keep on hearing about, Vartur and all of them, which are so polluted? Are they not getting?
They're also going to get. So Agara is getting treated wastewater. So many, including Vartur and Belandur, will get treated wastewater very shortly.
And this is after they're doing whatever they have to do to control the pollution that's actually happening in those lakes already, or how is that?
The thing is that in India, we don't have an absolute choice, right? So before this, there was untreated wastewater going into the Vrishpavati and the Dakshin Pinakini. And farmers were actually taking untreated wastewater and using it. They were pumping it up to 22 kilometers on their own and reusing it, right? So now, once we get into the formal terrain of treatment of used water, then we have better science that we can throw into it, including AMR, ARG studies and other emerging contaminants. And we can then design systems so that it's safer and safer as things go along.
Makes sense.
And so it's also that the farmers are not only getting the wastewater, but that the food is coming back to the city. Therefore, we need to be completely careful both on the rural and urban side simultaneously, right?
Yes, correct.
And no other city is doing this kind of a study analysis. It's being done from a wastewater epidemiology perspective to understand community health, but from a reuse health and from a agricultural reuse, I
Correct.
don't see any other city working on this.
No, absolutely, you're right. Avinash, you had a same question?
Yeah. No, Varsha, so just the reflections again, if I look at these sides and if I look at that last point about ethical, because year-round water, which is tested to be safe, right? Especially if I pick up that point, and the challenge also is that, I mean, our monitoring systems and both the COVID wastewater surveillance experience, or if you imagine how a Devanalli town or or a panchayat, in these areas, how could any of this monitoring talk to the health systems, right? I mean, what are the challenges? Because finally, unless we tie all this up, how do we see this being safe on an ongoing basis?
Right.
What happened in COVID surveillance? What did BBMP do with this? How did the health systems respond? And how can we imagine some of these things, say, for a Devanalli, right? I mean, any reflections and thoughts from you for that?
No, I actually think that there's been absolutely like zero interest from the health system for something like this. They don't care. COVID also they cared because it was an emergency and there was a lot of like political and community pressure and things like that. And it was a true pandemic and people had to like there was a lot more sort of openness, I think, in the health system generally to look at alternate ideas. Now there is no pandemic, there is no emergency. We've had zero, like nobody cares, honestly. Where we have actually had interest is actually from Vishwanath's conversations with the water guys. And even in UP, when we went and spoke, it was not the health department that was interested in this, it was the environment department that was interested in this because they had that mandate from Namami Gange. So we do not see, at least in my experience thus far, when I brought this up, so AMR right now is getting a lot of attention at the national and the state levels and things like that. And there's been a lot of trainings and things like that from the NCDC, which is the National Communicable Diseases Control Program. They are like, we are very interested in AMR, but we right now want to focus on human and veterinary AMR, like diseases in humans and diseases in animals. We understand that there may be some component of environment contributing to this, but this is not there in our mandate at this point of time to do anything much about it. Where they had a lot of interest was actually in the data that I just mentioned about when you keep the water out in the sun, when you keep wastewater and you keep this soil or whatever out in the sun, and you allow the sun to kind of beat on it for a couple of days, then you have a reduction in pathogens and presumably in antibiotics also. And this is only a hypothesis. So when this they were like, this is interesting. If you have any data on this that you can publish and show us, then we would be interested. So again, it's a very specific question that health departments would be interested in, not an overall kind of water related stuff is what I got.
Yeah, one of the key challenges, Varsha, also is that people are interested in finding problems. You want to find heavy metals, you want to find AMR, want to find ARG, because it then gives you a paper and it gives you this prominence and publicity. But then to do the long-term grind of finding solutions for that, there are very little folks who are actually working on it and trying to figure out how those solutions will also emerge. Apart from saying control the use of antibiotic, which may occur to some extent, but eventually people will be consuming antibiotics and there will be residuals, right? Whatever you do with the control mechanism there.
Right.
So therefore, what do you do post the presence of this in water bodies and soil is very crucial. As you were rightly pointing out, very little money is coming in this kind of studies?
Yeah, you also actually reminded me that in my antibiotic slide, I only focused on the 4 antibiotics that we found. I didn't focus on the 16 antibiotics that we didn't find. So
This is my grouse with you folks who are the researchers. The evidence of
yes,
absence is also a powerful evidence which needs to be worked on.
absolutely, absolutely. And I actually should thank Avinash for bringing up that point about what did you find about the AMR bacteria? We did not actually find that many resistant this thing. So those are things I should also highlight, not just the presence. You're right.
Varsha, shall I stop sharing the PPT?
Yeah. And I guess we're also almost out of time, no? 5:30. Almost.
That's okay. We can. I mean, if there are more, there are some questions in the chat. Are they? Oh, no. So Sania Patel is asking if the non-degraded drugs are the ones detected. Could it also be that? How you read that?
Yeah, I responded also. I said to be this thing.
Right. So I was actually wondering about that baby.
Yeah.
Who test you all did. So I was just wondering, maybe because AMR can also be passed through breast milk. So maybe the kid got it from
potentially. Yeah, could be. These are again questions that we don't know how to answer. So
totally. And now people in Maharashtra are going nuts over this Guillain-Barre.
Right.
It's a rare disease suddenly spreading all over the place.
Correct.
Any other questions, folks? Is there anyone here who has been wondering what this Kere Sanjeevani project is all about? If anybody wants some more details about that, we can tell you.
Yes, hello, my name is Arun Kumar Sridharan. Yes, I'd like to know about the project, Kere Sanjeevani project.
Varsha, you want to take it?
Yeah, can you just actually go back to sliding the this thing? I can just talk about it. And
sharing the slide? Okay.
Yeah. There's a slide just specifically that newspaper, this thing, picture of the...
Tell me when to stop.
Yeah, you can stop here.
Okay.
So Arun, hi. Basically, I showed you this previous slide about how the districts surrounding Bangalore are quite dried up. And one of the reasons for that is, of course, like rapid urbanization and sort of population explosion of Bangalore. A lot of the groundwater in the surrounding areas basically depleted very rapidly. But these are also districts that are traditionally quite arid. They're also agriculture heavy. So they require water, but they don't have any water. And you might have heard just now from Vishwanath's comments that, farmers are basically pumping untreated wastewater because they're desperate for water, 22 kilometers or so to get to their fields. And so that was a whole section on untreated wastewater that I'm not going to go into, but this is something that happens quite a lot in not just in Bangalore and its surroundings, but really a lot of the country. About 5 years ago, Bangalore decided through a very large political process that its wastewaters were going to be treated and pumped to lakes in around it. So east towards Kolar, one district, north towards Chikballapur, and southwest towards Ramnagara, which is on the way to Mysore. So to these 3 lakes, to the dried up lakes in these 3 districts, treated wastewater was getting pumped to rejuvenate the lakes. The idea was never that the water would be directly utilized from the lakes. The idea was that the pumped water in these lakes would recharge the groundwater. And so now you use the water in your wells and in your bore wells and things like that. And that becomes a source of water for your agriculture. So that is the Kere means lake. Sanjeevani is, of course, Sanjeevani, like rejuvenation or revitalization. That is the sort of the background of the Kere Sanjeevani project. And in this particular aspect, this particular section, we only looked at the lakes in this Chikballapur, the 4 lakes in this Chikballapur area. Actually, not even 4, 2 lakes in Chikballapur area. and looking at specifically on AMR over here. Does that answer your question?
Yes, great. So the problem is that most of, instead of allowing the groundwater levels to recharge, farmers have been directly consuming it, right? So are you able to estimate how much the antibiotics have degraded by the time they reuse it, or by the time the water reaches there?
Yeah.
Or what fraction of the antibiotics, what is the half-life and so forth, right?
Right. So we don't know so actually when you go back to that antibiotic slide, there are places basically where you see, so you have the outlet from the outlet STP in Bangalore, where this is treated water that's coming out. So you have the measurement of the antibiotics there. And then you also have it at the first lake, the open wells near the lake, the bore wells near the lake, that one. If you look at this, you see that you have the inlet and outlet, but you also have bore wells, you have open wells. So you do see fluctuations, but you don't see terribly major fluctuations between the bore well and the outlet. So for example, the water from Bangalore goes directly to Sihinir and as well as Kandavara. That's where it is. That's how it's pumped. You see a reduction in Sihinir. For example, in isoniazid between Bangalore and Sihinir, there's a small degree of reduction. And then when you look at Kandavara, there's still another reduction in the inlet and the outlet. But again, in the bore wells, it kind of goes up again. And we don't know why. So it does seem like there is some degree of reduction from one lake to another as it goes. Perhaps not so much between open wells or bore wells. But there does seem to be some other kind of factors perhaps in play with the bore wells. But these are still very early. And like I said, again, this is only for the 4 antibiotics that were there. The 16 antibiotics, there was actually nothing at all. So we can't actually do it in those cities. We don't have data. Well, we have data, but we can't do these kind of calculations for those 16 antibiotics. In these 4 antibiotics also, I would be I don't know if I'd be able to estimate exactly how much is the degradation just based on this. I think we would have to do much more studies on that to look at.
Would it be, thank you. Would it be fair to say that almost all these antibiotics are organic compounds, or are there some other inorganics as well?
Organic meaning, you mean like produced by
living? No. I mean carbon compound.
Oh yeah. For the most part, yeah. Actually, all of them are. Yeah.
Yeah. Okay. So they should be biodegradable. I mean, they should be.
Oh, absolutely.
Given enough time in the lake, if
yeah,
given the right conditions, it should be broken down.
Absolutely correct.
Okay. Great. Thank you.
Are there any other questions from anyone? Shall we? Okay. If there are no more questions, shall we conclude the session? But before that, I'd just like to thank you, Dr. Varsha Shridhar, for an insightful and a very thought-provoking session, and especially for simplifying a very complex topic for all of us, for our audience, and showing us that like in order to address AMR, we require collaboration across multiple disciplines and between environmental science, public health, and policy, that they must all work together to create sustainable solutions. So thank you all. And for our audience as well, we look forward to having you for further Biome Academy sessions. So keep an eye out on it on Instagram and on our LinkedIn channels.
Thank you so much. Really, really appreciated the opportunity and the patience and the engagement. Loved it. Thank you very much.
Thanks, Varsha.
Thanks, Uma. Bye, everyone. Thanks.
Yeah.